Hi there and welcome back. Let's review chronic pain. Pain is a disease. Now, most of the time you think of pain as a symptom of a disease, and that's true most of the time. It's the symptom of a tumor or an infection or an inflammation or an operation. But about 10% of the time, after the patient has recovered from one of those events, pain persists. It persists for months and oftentimes for years. And when that happens, it is its own disease, chronic pain. To better understand the chronic pain, let's talk about allodynia. Imagine I am stroking your arm with a feather, but your brain is telling you as if I am stroking you with a hot torch. So even the slight touch of a feather makes you feel like excruciating burning pain. The medical term for this phenomenon is called allodynia. How can the nervous system get this so wrong? So we need to understand how the nervous system works. Imagine that the nervous system in the body is hardwired like your house. In your house, wires run in the wall from the light switch to a junction box in the ceiling and from the junction box to the light bulb. And when you turn the switch on, the light goes on. And when you turn the switch off, the light goes off. So friends, imagine the nervous system is just like that. If you hit your thumb with a hammer, these wires in your arm, that is, of course, we call nerves, transmit the info into the junction box in the spinal cord, where new wires, new nerves take the info up to the brain, where you become consciously aware that your thumb is now hurt. But the situation, of course, in the human body is far more complicated than that. Instead of it being the case that the junction box in the spinal cord is just simple, where one nerve connects with the next nerve by releasing these little brown packets of chemical info called neurotransmitters in a linear one-on-one fashion. In fact, what happens is the neurotransmitters spill out in different dimensions, laterally, vertically, up and down in the spinal cord, and they start interacting with other adjacent cells. These cells, called glial cells, were once thought to be unimportant structure elements of the spinal cord that did nothing more than hold all the important things together like the nerves. But it turns out the glial cells have a vital role in the modulation, amplification, and in the case of pain, the distortion of sensory experiences. These glial cells become activated. Their DNA starts to synthesize new proteins which spill out and interact with adjacent nerves, and they start releasing their neurotransmitters, and those neurotransmitters spill out and activate adjacent glial cells, and so on and so forth, until what we have is a positive feedback loop. It's almost as if somebody came into your home and rewired your walls so that the next time you turn on the light switch, the toilet flushed 3 doors down, or your dishwater went on, or your computer monitor turned off. That's crazy. But that's in fact what happens with chronic pain. And that's why pain becomes its own disease. The nervous system has plasticity. It changes and it morphs in response to stimuli. Enough about the nervous system. Let's talk about the treatment. Many medical treatments for pain carry potential morbidity and mortality risk, especially if they are used over a longer term. Examples include GI bleeding with non-steroid anti-inflammatory drugs use, renal or hepatic toxicities with acetaminophen overuse, development of medication dependency and or abuse, plus sedation related impairment while driving, etc. with narcotic analgesics, methadone and combination therapies. With the use of opioids and some multi-drug therapies, often opioids and anxiolytics in combination, there is a risk of accidental or intentional overdose. This is true for opiates administered by various routes, orally, transmucosally, via absorption of intraoral liquid, nasal spray or rectal suppository by injection, transdermally via dermal patch, or intraspinally via pump or and catheter. The incidence of overdosing events and mortality involving narcotic analgesics, methadone and combination therapies have increased greatly in recent years according to CDC statistics. The presence of comorbid medical conditions, including current or past history of psychiatric disorders, depression, bipolar, you name it, alcohol or substance abuse in persons with chronic pain must also be considered in assessing the risk. So look for, as far as the treatment, look for morphine, oxycodone, hydrocodone, methadone, and of course these are the generic names, and you will see brand names for these medications from time to time in the medical records. So what are the appropriate underwriting requirements that we have to better assess the chronic pain? First and foremost, RX check industry-wide has become a very popular tool to correlate regardless of chronic pain, but when it comes to underwriting chronic pain, RX check is the best tool to dig out more details and to better correlate. And needless to say that you can add a full drug screen on your routine lab, and of course the medical records in addition to routine age and amount requirements per your company specifics. So how do we underwrite this? Basically look for the specific diagnosis associated with the chronic pain, the location, intensity and duration of pain, functional abilities including mobility, occupation, social support and activities, any associated medical or psychiatric impairments, history of any drug or alcohol abuse, details of treatment and treating physicians, details of medication use, the number, the types, the doses, frequency. Do you see any recent medication changes in the medical records? How about the stability of pain symptoms? Do you see any self-prescription or a pharmacy check suggests multiple sources for pain prescriptions? Are there any indication in the medical records to support that there is medication abuse or misuse? Do you see any opiate infusion pumps or multiple opiates at high doses? As said before, any additional medical impairment, especially obstructive sleep apnea, chronic or recurrent depression, and so on and so forth, and the list goes on. So what you need to do is plug these details into your company specifics, the underwriting manual that your company expects you to follow. Plug those details and come up with the best possible offer based on the present evidence. Let's start here and see you soon. Take care. Bye now.